Aircuity, even understanding that building interventions can optimize human health. Believe it or not, many people in the building profession don't consider that factor. So I want to say hi. You can see me, but here I am in case you couldn't see me. I'm not here alone. And behind me is my faithful companion, Luigi, the puggle. I imagine several of you have dogs or children or cats in your background. So in the next 45 minutes, I want to go over really 3 aspects of how the built environment is affecting or can affect human health, with a focus clearly on what we're in the midst of right now, the COVID-19 disease outbreak. So I want to talk about how this pandemic has really jolted our sense of priorities. I want to talk about some new studies on the human being in our current environment, which is indoors. And then I'd like to talk with you about how we can take the information from these studies and move forward in a new way that will actually be much more beneficial for human beings. So to get started, what I'm calling the cloud of COVID-19 and the silver lining. But before I jump into the real meat of this presentation, in case you're wondering why I, as a physician, as a pediatric oncology, am talking to everyone who's somewhere, probably near Boston or wherever you are. So my journey to presenting to you really began when I was in medical school. So I decided to go on an adventure. When I was about 24, I was in med school. I decided to go to Papua New Guinea and do medical work for a couple months. So I went to New Guinea, which is on the equator, north of Australia. It was amazing. I traveled in that canoe and lived in these sort of thatched huts. And the hospital that I was stationed in primarily was in Papua, was in Wewak, called Wewak General Hospital. And you can see it wasn't exactly the kind of hygienic condition that we're used to in this country. The middle part shows the men's tuberculosis ward, and on the right, that's me looking at a patient we were going to do surgery on. I'm wearing flip-flops, which was the normal footwear. The surgical nurse was not wearing gloves. But despite these conditions, these patients did not get new infections from the hospital environment, and it was kind of surprising. It didn't strike me so much at the time, but going forward, hang on. In this country, and I didn't realize this until I was finished my fellowship and I was practicing pediatric oncology, going into the hospital is actually the 3rd leading cause of death in this country. And this is before COVID-19, so I'm not sure how that changed things. But the little girl in the middle is one of my pediatric oncology patients. She survived her cancer, survived her chemotherapy, only to get an infection that I thought had something to do with the building. The man on the left is the dean of my son's medical school. He was skiing in New Hampshire, had an accident, messed up his meniscus, went in for a 1-day procedure, came out 4 months later without his leg and almost without his life from a MRSA infection. And so they say that about 6% of patients get these infections. I think actually it's worse than that, but getting the numbers is difficult. So I thought about this and I thought, well, I think the building has something to do with this. And yet as a physician, I didn't know how to talk to the building managers, and the building managers didn't really have much interest in talking to me, which is why eventually I went back and got my degree in architecture and designed hospitals for several years, because I felt like I needed to understand the building. And actually, going back to medical school again, this is my wonderful mentor, Dr. Folkman, and I worked with him for 6 years doing research. And we were studying the growth of blood vessels to cancer cells. And we were using black mice for this part of the experiment. And I called Dr. Folkman around 11 o'clock at night, and I said, you know, something's going wrong with our mice. Control mice are dying, study mice are dying. Doesn't seem to be related to cancer growth. So he came in the middle of the night, and we scrubbed the operating room of the lab down from top to bottom. And Dr. Folkman said, never, ever underestimate the power of the environment in clinical outcomes, but not just in clinical outcomes, because we're not really going to be talking about hospitals. Never underestimate the power of the environment in human health. So that's what I want to talk with you about. All people in all buildings. So speaking of our environment, you know, we're really indoors about 90% of the time. That's why I say we're homo indorus now. And if you look over time, you know, a long time ago, we lived in dwellings that had a lot of communication with outdoor air, soil, plant material. And then our buildings became more sophisticated. We developed sanitation systems. And really by the, you know, Industrial Revolution, we were working indoors unless you were in agriculture. And then moving up to now, you know, many of our buildings are, especially where we work, have sealed windows. They're very warm. We can come to work in bare feet if our bosses allow it. The indoor environment is really quite separate from the outdoor environment. And concurrently, we have seen a rise in infectious diseases. So, you know, I made this slide before COVID-19, but so we don't really have to, I don't have to convince you of the threats of infectious disease. But it's not just infectious diseases that have been on the rise. A lot of inflammatory-based diseases, a lot of autoimmune disorders and allergies have increased. So how can we begin to take a look at whether or not, in fact, there's any sort of causal relationship between the way we're managing our indoor environments and these changes in disease rates? So let's talk about what the reason that I'm here in Stowe, Vermont, and you are wherever you are. We're not in the same building because of this coronavirus, the SARS-CoV-2 that causes COVID-19. So let's just for a second talk about coronaviruses. They're actually very common. They cause about 30% of the common cold. The thing about RNA viruses is that they mutate very easily. So the genetic material that governs the way the virus behaves is RNA, as opposed to DNA, which is what human beings and mammals have as their primary genetic material. But coronaviruses are RNA viruses, and they mutate incredibly quickly. It's kind of like my son, who's now a physician, so he did do well in school, but when he was in the 8th grade, he would write a history paper or an English paper, and he would write and write and write, but he wouldn't proofread. And so when he handed it in, there were a lot of mistakes. So this is relevant because with RNA viruses, they don't have the proofreading mechanisms that DNA viruses or DNA bacteria have, which is why most pandemics have been caused by this category of viruses. So just to take a look, we're not going to get into molecular biology, but this virus, this strain of coronavirus started in some animal reservoir. It mutated, and then in that mutation, certain viruses were able to survive in a previously hostile environment. And because as human beings, we didn't have any immune memory against this strain, the virus had no competition and is able to infect us fairly easily. So our environment is providing sort of the living conditions for this this RNA virus. And unfortunately, the mutation also allows this SARS-CoV-2 to attach deeply into our lung tissues versus higher up where we wouldn't get so sick. So it's not just this virus. Influenza A and viruses and bacteria in general are able to mutate and evolve more quickly than humans. So I have 7 dogs, and I went to the vet in November for some reason, and my vet said, "You need to vaccinate your dogs against influenza." And I was like, "Oh my gosh, don't you make enough money off of me already?" And he said, "No, really. Some viruses have evolved to live in our pets." So my 7 dogs said to me, "Look, don't blame us. You can blame us for some things, but don't blame us on the flu." And speaking of dogs, do not worry about your dogs giving you COVID-19. There's only been 1 dog in the US that got COVID-19 from their humans, and there's no history, there's no data showing that dogs can give it to us. So this slide is about the flu. I don't want you turning your dogs out into your backyards. But clearly this, we're experiencing something that most of us have never experienced before. But there actually is a silver lining, especially for everyone who's listening to this. Anyone who's in the building industry is going to have their jobs, if you can take this perspective. Your work is now more important than all of the physicians in the US. And you'll see why I believe that. So in the past, we valued our buildings to protect us before COVID, and we still focus on energy efficiency, LEED, and just sustainability in general is a primary focus in building design, operation, and management. But now this COVID-19 epidemic has really brought the use of a building to protect our health into focus. But when I was looking at the Aircuity website, I said, wow, you guys already are way ahead of most building professionals in realizing this. So that's really impressive. So let's talk about some studies that begin to examine the relationship of the building and human health. So if you were going to design a study to do that, think about, okay, what kind of building would we use? What kind of building metrics would we capture? What health impacts could we measure? So for example, in your home, you could say, well, I'm going to measure my temperature and lighting and sound. I'm going to see how many days sick my kids are from school, or if you were in an office building, you could measure absenteeism. But a really great building to use for this experiment is actually a hospital. Sorry, I got ahead of myself. So let's take a little bit of a closer look on human beings indoors. So up until recently, if we wanted to understand what microbes, what bacteria and viruses are in our bodies or in our buildings, we would use what's called tissue culture techniques. You take for example, if you have a sore throat, you swab your throat, or your primary care provider does. You plate that swab out on a petri dish, you incubate it, and you see what grows. That's called tissue culture, and it's very valuable. However, we only were identifying the microbes that made us sick. And it sort of created a us versus them attitude. COVID-19 has created an us versus them attitude. But there is a bigger picture. So we can now look at bacteria, viruses, and fungal organisms much more carefully and with much more accuracy, because we can use these new tools, they're called metagenomic tools, where we actually look at the DNA and RNA fingerprints of the bacteria and viruses in our bodies, on our bodies, and in our environment. And what we've learned is that tissue culture was only showing us a small percentage of these microbes. And tissue culture was only showing us the ones that made us sick, because there's this whole universe of microbial life that actually lives in us, on us, and in our buildings. So this might not sound reassuring, but each of us, by cell number, is only about 30% human. The rest of us are primarily bacteria and some viruses. And by volume, that's about 2 gallons. Each of us is about 2 gallons bacteria. That's kind of startling. Most of these are good for us. So I want to show you this animation based on research. So as I'm talking and you're all breathing, little droplets come out of our airways. They carry the organisms in our mouth, noses, throats. You can see this engineer's working away. She's spreading her skin cells onto the paper and desk. That's normal. They carry Staph aureus and all the normal bacteria on her skin. You can see that there are particles coming out of her nose. That's, again, normal. You can see that her gastrointestinal tract is illuminated. We have a lot of bacteria in there. If she had a gas issue, you'd see that. But you can see that the human being, this woman, is shedding a lot of microbes into her environment. And in addition, microbes and particles that are on the surfaces are resuspended into the air and settle out again onto surfaces. And then depending on how sealed your building is, you'll have more or less exchange between the indoor microbial life or microbiome and the outdoor microbiome. So not surprisingly, each of us as an ecosystem of organisms enclosed, we shed all of this into the buildings we occupy. And this is really remarkable. The bottom part of this slide is telling us that we now know that depending on how a building is designed, used, and ventilated, certain organisms are going to survive and certain ones won't. So if you think about that, what that means is the indoor environment is now the most powerful evolutionary driver. The indoor environment is now the survival of the fittest, if you remember Darwin's statement. So our buildings are now determining which of these microbes are going to survive, which will then impact our health. So back to the hospital. So I want to tell you about 3 studies that look at how the indoor environment impacts human health. So this first one is in a brand new academic hospital in the Chicago area. It was beautiful. It's a beautiful hospital, LEED silver. All the rooms are private. So I found out about a group of microbiologists who wanted to track the microbes through the hospital, starting from before it was even occupied. So this study takes place over 13 months. And this group took 10 patient rooms and monitored all of these environmental conditions every 5 to 30 minutes. So they had about 8 million patient room data points. So you can see temperature, hand hygiene, pressurization, lighting, CO2, humidity, traffic, room air changes, and outdoor air. So just think to yourself, which of these parameters do you think might be correlated with new patient infections? They used to be called nosocomial infections. Now they're called healthcare associated infections. You know, we hear a lot about hand hygiene, clearly. So I found out about that study and I said, hey, I'd like to look at the patient outcomes in those rooms. So I had about 350 patient outcomes to correlate with the other data. So after 13 months, we sent all this off to our statistician, who came back and said, of all of those parameters, when the relative humidity in patient rooms went down or was low, the infection rate was high. And as that patient room relative humidity climbed a little bit over 40%, the infection rate went down. So I looked at this and I said, oh my gosh, it's clearly seasonal. They must have missed some other variable. So we fired our statistician, got a new one, said, tell us what we expect. And the new statistician came back and said, no, this is a powerful and independent variable, separate from all of the other parameters. Low relative humidity in the patient room was associated with higher infections. So I was still skeptical. So we did a study in, we're actually in year 6 of this study, in a nursing home, looking at patient infections versus environmental data. So again, we sort of focused on temperature, humidity, and travel in and out of the patient spaces. And then we looked at both viral and bacterial infections, as well as some other cognitive functions. But let's just talk about infections. So after 4 years, we analyzed the data, and once again, we found that when the indoor relative humidity was less than 40%, especially respiratory and GI infections were high, and that the infection rate came down between 40 and 60%, we had the lowest number of infections. So this nursing home, after the first 4 years, has maintained their indoor humidity in this range, and they've had no COVID-19 infections in staff or patients. So this is a pretty remarkable study. So both of these studies look at correlation. This is a study that was done by the Mayo Clinic looking at children in a preschool. So they took half of a school and humidified it to 45% and let the other half do what buildings do in the wintertime. This was January into March. So, you take cold outdoor air, bring it into a building, heat it up, and unless you humidify, the relative humidity is going to plummet. So they found that when they looked at the number of airborne particles carrying influenza, this is using the metagenomic techniques, they found that the non-humidified part of the school had over twice as many infectious particles in the air compared to the humidified part. And secondly, they found that the actual virulence of the virus was greater in dry air. So that's separate from the number of particles. The actual infectivity was higher. And we don't understand that phenomenon yet. And then most importantly, you can see here on the right that in the humidified part of the school, you had almost a third of the number of absent kids as in the other part of the school. So if you're kind of zoning out or on your phone or talking to your spouse, the take-home message from that study is in the humidified part of the school, you had many fewer kids absent from influenza. Okay, so let's just take a look at COVID-19. What aspects of your indoor environment are going to determine if this person is sick and they come into your home or your office? What's going to determine your vulnerability to getting this infection? So there are actually 3 places where you can decrease the transmission of, in this case, infectious disease. Number 1, the viral load from somebody who's already sick. So on the left, you see behaviors. So that would be, how do you control the viral introduction? So wearing a mask, social distancing, hand hygiene, cleaning surfaces will all decrease the number of viruses brought into your space. And then in the middle, we have viral transmission. So in the air, on surfaces, through large droplets, small droplets. And then thirdly, the third component that is going to affect whether or not you get sick is how robust your immune system is. So that's where you focus on vaccinations, being well rested, hopefully eating well, just keeping your health up in general. So the middle part there, how is this virus transmitted, is controversial or has been controversial. But the fact of the matter is we have enough data that we need to accept that the SARS-CoV-2 virus does spread through the air in fine aerosols. greater than the 1 to 2 meter distance that large droplets spread. And one of the first studies that indicated that this virus is spread through the air is this study in an ICU in Wuhan, where you can see the patient bed, and then viral RNA was recovered up to 14 feet away in the exhaust grill and out in the hallway, and in spaces the patient hadn't really come near. So this was one of our first studies showing that the RNA is recovered from an airborne route of travel. So, okay, we now know that when the relative humidity of the air is less than 40%, you have greater aerosol transmission. It's harder to clean surfaces because you have resuspension and recontamination. And for reasons we don't understand, the virulence, the infectivity of many viruses and bacteria, not all, but many, is increased when the air is dry. So again, I'm talking, you're breathing, droplets come out about 100 microns in diameter, and in a 20% relative humidity room, those 100 micron droplets shrink very rapidly to become what are called droplet nuclei, the 0.5 micron diameter. And in general, we can find those droplet nuclei, hours, days, weeks later, and having traveled great distances. And we used to think that any bacteria or viruses in those droplet nuclei were dead. But we now know, using these new metagenomic techniques, that that's not the case. That with many viruses and bacteria, even though they're desiccated, once they're rehydrated, they are still highly infectious. And this is fascinating. If anyone can figure out how this happens, you'll get a Nobel Prize. So this study shows that with Influenza A, when the relative humidity is below 40%, the infectivity is high. But when you reach 40%, the actual virility or activity of the virus, we're not talking about number, we're talking about the actual viability. The viability plummets at 40%, and it stays low with many viruses and bacteria between 40 and 60%. And then the infectivity goes back up again, often. So that's Influenza A. And if you look at this coronavirus, we're finding the same thing, that the black line shows viral activity at 20% relative humidity and about 71 degrees, indoor conditions, indoor temperature. And you see that with the low humidity, the virus stays very active. At 80% humidity, the activity is diminished somewhat. But if you look at the blue dotted line, at 50% RH, so right in the middle of that 40 to 60% sweet spot, you have the lowest activity. And again, we don't really know what happens to the viral RNA in this case that makes it less infectious. Okay, so how am I doing here? Oh, pretty well, okay. So we've been talking about pathogens, the bad microbes. We've kind of ignored all of the good microbes because we don't have time to talk about everything. But while pathogens do very well in low relative humidity, humans do not. We were not designed to live in these low water vapor states. So the average person in a room with 20% relative humidity will become clinically dehydrated to about 1.5% of your body weight in 8 hours. And it's not just your skin. So I'm supposedly about a 50 kilogram person. I have half of a tennis court in surface area, including the double alleys. That's how much surface area I have that can lose moisture to the environment. So you think about it, you have to include all of the area of your respiratory tract down into the alveoli, the little gas exchange places in your lungs. So we each have a huge surface area that can release moisture to the environment. And So maybe you're thinking or reaching for your water right now. So drinking water helps. Clearly, it helps us stay hydrated. But unless you have an IV running, oral rehydration cannot keep up with the fluid losses from your respiratory tract and skin. They're different tissue compartments. So when you're 1 or 1.5% dehydrated, which is how maybe a lot of us are by 2 in the afternoon, your brain function is diminished. People get tired, concentration lags. You might start feeling a little bit depressed or anxious. Our eyes become scratchy and maybe tear more. Our skin is affected, and clearly our respiratory tract. So let's just focus on our respiratory tract. So now we talked about microbes in the indoor environment, and now we're talking about human beings like us. So a really great study came out last May 2019. This was done at Yale. So Dr. Iwasaki was asking the question, why is it that we get the flu? We get bad cases of the flu when in the winter, when we're in these low relative humidity environments. So the study required that lungs be taken out and tracheas be removed and examined under a microscope. So instead of doing that in humans, which would have been unethical, obviously, Dr. Iwasaki used genetically engineered mice that respond to the influenza virus the same way we do. So she was asking the question, why is it at 50% relative humidity, you might get a little bit sick, but at 20% you get really sick? So let's think about our initial defense mechanisms against a respiratory virus. So if there's influenza or the SARS-CoV-2 virus in the air, and you run the risk of inhaling it. So here it is in the air, you inhale it. The first line of defense of just natural protection of our body is the mucus that lines our nose, throat, and our respiratory tract. And in that layer of mucus, from about your throat down into your lungs, are these little hairs called cilia that are constantly waving upward to help prevent these things from settling down into your lungs. And when you inhale dry air and that mucus becomes even 6% more viscous, the cilia cannot work. And this is what happens with people with cystic fibrosis. The mucus becomes more viscous, the cilia can't work, and people get more pulmonary infections. And subsequent to that, when you're fighting an infection, after the cilia hopefully clear the particles, say something does get into your deeper respiratory tract, these other cells come in, these macrophages and dendritic cells, that help limit any damage and heal any inflammation that does occur. And they release these proteins called interferon. And eventually the next leg of your immune system kicks in. But this lab found that at 50% relative humidity, all of these mechanisms work perfectly. But at 20% relative humidity, they don't. And not only is the mucus more viscous and the cilia can't work, but the cleanup cells are impaired and there's less production of protective proteins that then stimulate the rest of your immune system. So for reasons that are much more vast than just dehydration of your mucus, low ambient humidity is not good for us. So you think about these 3 steps that we talked about a few minutes ago. We're being told to wear a mask and to, the social distancing and, everything else that we're trying to control through behavior. And then you think about the environmental transmission, and then you think about the vulnerability of the secondary person. The thing about relative humidity is that it benefits both the second and the third step. And by the way, I should have told you this a while ago. I do not sell humidifiers. I don't even really know a lot about humidifiers, except that I humidify my home now. I just wanted to make that clear. But when you do maintain the relative humidity in this sweet spot, you decrease the burden of infectious virus in your air, and you support the health of the building occupant. And you can have this presentation and go over these slides more slowly. This isn't entirely new information. This Sterling-Avondale chart goes back to 1985. And even back then, they found that bacterial infections, viral infections, respiratory infections in general, allergies, and ozone problems were the least problematic, between 40 and 60% RH. And so if you take all of these new genetic analysis techniques and our ability to monitor human health and activity and productivity, we are still finding this sort of Goldilocks zone, this 40 to 60% RH, where humans are healthy and the bad microbes, the pathogens, are least bad. So I actually think this was Mother Nature's way of giving us an opportunity to survive against rapidly mutating pathogens. Because you think about it, when we're outdoors, you know, it might be cold or hot, but the relative humidity is in a fairly good range. But then you bring that outdoor air into your buildings, especially in the wintertime, and you heat it up. And if you don't humidify, you've suddenly created a separation between the sensible heat of temperature and the latent heat of water vapor. And I think that this disconnect that we've created in our buildings is a lot of what's driving these disease trends. So how do you change? How do you change building management to encompass occupant health? How do you begin to think about humidifying your buildings? You know, there are all these factors that must be aligned. You have to know why you're doing it. You have to trust, hopefully trust me. You have to believe the data, and you have to have the capacity. The way these factors are aligned is always a financial driver. But however, looking at humidification, when the return on investment is clear, you're going to find an indoor environment that's got a humidity between 40 and 60%. If you're a primate research animal at the NIH and your death is going to be expensive and disruptive to the experiment, you're going to be 45 to 55% RH. If you're up in the space station, NASA has figured out how to humidify in space. Or if you're a famous painting or a valuable old book or piano, you're going to be in a great humidity. So just as an aside, this is my son, Colin, who's he's an ER doc at Mass General. And last spring, he and I were hiking in Peru. That's like a good trail on the right. We were up in the middle of nowhere, and we came upon this little building that was like a mausoleum. And we went in, and there were the important village leaders who had died. And I guess they were embalmed and then sort of put in a sitting position and covered up. But you can see there's a humidifier and a dehumidifier and a hygrometer and thermostat over on the left. Sorry, Louie. Shh. Excuse me, guys. Louie, no. Sorry about that. So eventually the building manager showed up, and I said, what are your goals here with this building? And he said, well, we try to keep the humidity between 40 and 60% because the corpses do better. And I thought, really? The corpses do better? What about us when we're still alive? Don't we have a dollar value? And in fact, you know, it's clear now when we're reluctant even to go to work or send our children back to school, go into stores, you know, the financial consequences of the building making us sick are absolutely huge. And if you look at the amount of money you spend on energy use versus rent or mortgage versus, say, the salary of your employees, if you can improve productivity or health, even by 20%, you're going to save a lot of money. And for example, that hospital where we did the study, in 1 year, they lost over $15 million of non-reimbursable costs from taking care of these infections. And they tied up 11,000 patient bed days with non-reimbursable patients. And had they, actually they have humidified, but this was before they actually did a renovation. If they had put this ridiculously expensive gas humidification system in, they would have seen a 500% ROI in the first quarter, just from decreasing their infections by 20%. So these are the kind of metrics that we need to bring to building owners and managers, to customers, to show them the value of human health. Okay, so in conclusion, what is the wake-up call from COVID-19? In my opinion, the wake-up call is we need to begin to manage our buildings with good occupant health as a performance metric. It's not just about the real estate value. It's not just about how many windows, or it's not only about fuel consumption. It's also about monitoring human health so that we design and operate our buildings correctly. In using this health lens, the first thing that's shown up, at least in the studies that I've been a part of or know of, and I'm sorry, I spelled humidity wrong. We now know that low relative humidity is harmful to people, and it benefits the bad microbes. So if any of you are thinking, why does she keep talking about relative humidity? Why isn't she talking about absolute humidity and dew points? And the reason I'm not talking about those design parameters is that it really is relative humidity that obviously encompasses temperature, that speaks to the evaporative, to the movement of water vapor, to vapor pressure. So my belief is that we can turn this trend around. And the first step that these studies have revealed is that low RH is harmful to human beings. So for me, first as a medical professional, I want to heal my patients. I want to follow the protocols. I don't want to get sued. And then building professionals, such as those of you listening and me somewhat now, we want to reduce energy use. We want to stay within our budget, follow codes. But if we can really learn to work together, we can help turn this COVID-19 thing around, and we stand to benefit in overcoming a lot of these scary disease trends. So we've talked about a lot. We've talked about new studies, new assessment techniques. We've talked about studies that actually show the impact of the low relative humidity on human beings, and we've talked about some of the cost consequences. So thank you. I'm sorry about the barking break there. So, and again, you can have this presentation, and there are all the references. Okay. And now somebody else is in.
That was great. Thank you so much, Dr. Taylor. We do have some questions. Do you want me to read them off, or do you want to? They're on the chat session, but I might as well just read them. It's very conversational. But if there's at the bottom of your screen, there should be like a chat box. If you just hit that.
Oh, yeah. Oh, your dog. I see Susan's comment. I don't know if I've seen the whole chat thing.
Okay.
Oh, okay. Sorry, I wasn't. Thank you, Susan.
It says, do you think the spread of COVID will decrease in the summertime when humidity levels are higher and when buildings are air conditioned? Good question.
Yeah, I do think that it's going to decrease when you say air conditioned. I'm not sure exactly what you mean by that, but
in wintertime, we're heating buildings and tends to dry out the air. In summertime, humider outside, and we're air conditioning. That also can obviously affect it, but typically buildings, I guess inside, the other question too, maybe this is from an anonymous, are buildings, have you seen in studies that the humidity in buildings is typically higher in the summertime versus the wintertime?
Yes. in general it is. Even if you're air conditioning and condensing out water vapor, you generally don't reach the low relative humidity in the summertime that you do in the wintertime in temperate climates. So I think the really important variable is relative humidity.
Yeah. And do you think, or the other question there was, do you think that that will have an effect, and you'll think the spread of COVID will decrease and that really, I guess that's in the coming months. So as we enter June, July, August, and maybe even in September, will that help? I guess is the other question there.
I do think it's going to help. I don't think it's the whole answer. Clearly this is a very infectious virus. We don't have immunity or herd immunity, as they're saying, which means that most of us are immune. So there are other factors as well, mainly the infectivity of it. But I definitely think that higher humidity in our buildings, higher than 20%, is going to contribute to decreasing the degree of illness that we're experiencing.
Yeah. I'm going to try to take some of that. So the next one was, well, there's a lot of questions here. Okay, so does relative humidity decrease the surface life of COVID-19?
Great question.
Yeah.
Yes, that's a really good question. Yes, it does. And there are several studies out, and the most recent one is actually by the NBAA, which is the National Biological, NBDAA, National Biological Defense something. It's basically Homeland Security research. And they have shown that the activity of particles on surfaces is also diminished when you get up to 45, 50% RH. So yes.
Yes. Great. It says, what about the risk of poorly maintained humidification systems which can serve as a source of infectious disease? I don't know if that's similar to air handling units, like, there's some UV treatment strategies for air handling units, or bacteria building up on coils, like a lot of the talks there. I guess it would be analogous to anything in an air handling unit that can then become, if it's not maintained, can become probably an assistant or help spread if those bacteria, like Legionnaire's disease way back when, the building could actually help spread those viruses. Have you ever been asked that question in terms of?
Yeah, for sure. Yeah. A lot, actually. So a couple things there. One, humidity per se is, let's talk about mold for a second. Humidity per se is not extracted from the air by fungal organisms. Fungal organisms need liquid water. So clearly if you have a thermal bridge, or you have a spot of poor insulation or a cold pipe in a warm, humidified environment, you're going to have condensation. The solution there is to insulate your building or your pipes. But back to the question about poorly maintained humidification systems. Yeah, not good. If you have a biofilm forming that is colonized by Legionnaires, you don't want to disseminate those. You don't want to disseminate those organisms into your environment. So the trick is, and I know it's not always easy, maintain your humidification systems. Yeah. Or, make sure that you try to prevent biofilm formation in closed spaces.
Yeah, good maintenance is key. Another good question here. Most buildings in colder climates don't have building envelopes that can accommodate 40 to 60% relative humidity without causing condensation inside the walls and on the windows. Would you recommend just increasing humidity to 30% if 40% can't be maintained?
So, yeah, I that's why the next stage of this building improvement is up to you guys. I'm just telling you why you should be humidifying. You've got to figure out how to do it. But back to the question, yes, 30% is better than 20%. But in terms of human health and the actual activity of organisms, there's something about 40% that is kind of a magical on-off switch for infectivity. So for example, I live in northern Vermont, and my husband was in the Air Force, and I don't know what he inhaled, but his lungs are, he messed up in some ways. And he would get sick every winter. He'd get the flu or a couple of bad colds. We finally started humidifying. And again, our house is an old farmhouse, and we do have to kind of adjust it when it's minus 20 out. But since we've been humidifying, he has not gotten sick once, which is pretty crazy.
Yeah.
But yeah, I mean, you do have to be realistic, but the real solution is to try to improve the building envelope.
Yeah, to accommodate. This is another good question. What are the impacts to health and varying ventilation as it relates to particulates? So there was a lot of that, and we obviously measure particles, and we're very concerned with that. And there's a lot of talk now that COVID's been more rapidly spread in high pollution areas and cities and environments, where I guess there's the thought is that the micro droplets can attach to a particle and then get deep into your lungs. So have you, in your studies, correlated the two of those, humidity to the particles?
Yeah, well, so that's a great question, actually. And yes, so especially the 2.5 particle, the fine particulate matter, is diminished from the airborne environment in that humidity zone. And there's a very good study that came out from the Harvard School of Public Health about 3 weeks ago showing that when you have higher 2.5 particulate matter, you have higher COVID-19 transmission. So what we're seeing is both a diminishing of particles and of infectivity in that once you reach 40%. So that's a great question. Yeah. And there actually now is data about it. And
was that Dr. Allen that published that, or is that somebody else?
It's not Joe. I think it's someone in the same department, but a different first author.
Oh, great. Okay. Well, that would be.
He looks more like VOCs and CO2, although he clearly understands the value of managing buildings for health. You've probably seen that book that he wrote, which is a really good book. This one.
Yeah. Yes.
There's a wealth of information in there. But he kind of like, I know Joe, and he kind of like doesn't focus adequately on humidity, but it's still a good book.
Yeah, great. This is really another great question. We see COVID-19 even in humid environments. How do you explain the high rise in countries like Mexico or even worse, Brazil, so where you do have these high humidity areas? So
a great question. And clearly we have the flu in Florida. So when you get over 60%, there tends to be an increase in the contact transmission. So in the direct, either touching surfaces that have been contaminated or the large droplet spread. But for example, with the flu, where we have a lot of data over decades, you don't have the seasonal trends that you have in cold winter climates. But you still clearly have the flu, but it's just more surface transmission, which is actually easier to control.
Yeah, take care of. Yeah. Wow, that was a good question, and that actually makes a lot of sense.
Great question.
Yeah. Can you comment on the additives that may be found in steam, which are released into the environment in steam humidification systems? Do you think clean steam is necessary? I think it's a very interesting question. I've been in buildings for 30 years, and I didn't know there was additives to steam. So any commentary there?
And also things become concentrated when you're decreasing the water volume. My rule of thumb is if you don't want to drink it, don't breathe it. There are health impacts of ingesting chemicals, whether it's through your respiratory tract or through your GI tract or through your skin. So yeah, be careful with what are they called? Direct steam systems. Again, you all know more about humidification systems than I do. Right. But if you can't drink it, don't breathe it.
Yeah, that's a great comment. There's I think we have time for one or two more, and then there are recommendations to increase fresh outside air, run the air handling units 24/7, and increase air filtration. Do you think these changes will have much of an improvement? I don't know if you're aware of this, but ASHRAE actually came out with this publication. And I'll just let you know that we've been very cautiously and talked to very large manufacturers like Trane carrier and such about this recommendation. We're trying to cautiously advise against, just because of how buildings operate under current systems, if people were to swing, especially as we enter the summer months, swing ventilation dampers wide open, you could run into control problems, if you will, and introduce high humidity levels and mold and other issues. So we're certainly we're doing controlled ventilations. We're very positive on ventilation as where and when it's appropriate, like we recommend in lab buildings and such. Very good, but we just would say Aircuity would say to be very cautious and make sure that your building can control and do that. And we also are advising people that one impact of this that's going to happen is the occupancy levels are most likely, certainly in this next period of 12 months or more, going to be much lower than they traditionally have. So what we believe is most important is your effective ventilation rate per person. So if you have a building that is half occupied and the systems were designed for occupancy of double or maybe even triple what they may be post-COVID back to normal, you're going to get an effective ventilation rate that's much, much higher.
Yeah.
So have you heard about the ASHRAE paper that was actually sitting on my desk? And thoughts?
I'm on the infection control, the epidemic task group and the environmental health committee. Everything you read in those documents about the microbiome or about humidity, I've been fought for.
Yeah.
Yes, I am familiar with the REVA document out of Europe says 100% outdoor ventilation, which I think is not a good idea. I think you have to balance the benefits of dilution ventilation, but you have to maintain your humidity, and you don't want to be driving your energy costs through the roof. And you mentioned some things, Dan, that your knowledge is a lot more sophisticated than mine, but I don't think we can run 100% outdoor ventilation in large buildings.
Yeah, and depending upon the climate, time of year, et cetera. Yeah. Yeah, we do a lot of work in labs and vivariums, and I think what we have proven, at least, is that it can be done. We have net zero labs, and they're 100% outside air. So you can do this. I think we were already moving. The well building movement was already heading in this direction. This is really just speeding up something that's been talked about and thought about for a while. So in one sense, I think the good news is that we know we can solve these problems, and we have done this in other building types.
Yeah, Aircuity you guys are really on the leading edge of this thinking. It's admirable.
Yeah, thank you. Yeah, we kind of been coining a phrase that all buildings are critical environments now, and I think that for us it rings true. The fact that I thought your slides were excellent. They make the point about the value of human health and getting people back to school and work in environments that are safe and conducive and productive, and doing it in a smart, intelligent way that's sustainable and still energy efficient. And we've done a lot of that in labs and critical environments that are more energy intense for years. We just need to bring that to the rest of the built environment. So
my way of saying that is engineers are the physicians of the future, and I believe that.
Wow, you've got some good statements there.
Well, that's just like, it seems really clear to me.
Yeah, so I think we're at time, and I'm guessing that there's questions still kind of flowing in. So I want to be very careful.
Susan said, I think hopefully the same Susan who likes my dogs. My dog said, could there be a follow-up? I'm here. I'm happy, very happy to be working with you, and so just let me know what works.
Yeah, thank you so much. I too like your dogs. That's a lot to take care of, but I loved a lot of the labs I saw there, which I grew up with.
My non-dog loving husband gets to take care of them a lot of the
time. Well, great. Thank you so much. The presentation was excellent. We've got a lot of questions. We'll make sure we share it. And there's a lot of building experts and people that are going to be involved in trying to improve the built environment as we go forward. So I think it's really appreciative, that you joined us and shared your expertise and your thinking with us. We can't thank you enough. So
you're welcome. So my email should be there on my presentation. So feel free to. I see some great questions on the board. So feel free to email me, and I'll try to be quick about responding.
Yeah, great. Well, thank you so much. Enjoyed the presentation. With that, we'll end it, and I look forward to talking to you again in the future.
Great. Thank you.
Stay
Thank you,
healthy.
everybody. Take care.
Thanks. You as well.
Thanks.